In this video, we will describe how to obtain radial access for left heart catheterizations. After consent is obtained from the patient, gather the necessary equipment. You will need a pair of sterile gloves, a mask or hair covering or surgeon's cap, a sterile gown, and sterile drapes. Chlorhexidine or other antimicrobial solutions should be used to prepare the access site. You will also need some local anesthetic, such as 1% lidocaine without epinephrine, as well as a syringe and a needle for delivery of this local anesthetic. You will also need some unfractionated heparin and nitroglycerin to be administered after access is obtained and intraprocedurally. Finally, you will need the puncture needle, another syringe, and the radial artery sheath itself with a dilator. Ensure all sheaths, catheters, and needles are flushed and devoid of air before use. In general, a puncture site approximately 1 cm proximal to the ulnar aspect of the radial styloid is chosen. This location is preferred as the radial artery runs relatively superficially in this area and also generally straight, thus increasing the likelihood of puncture success. Furthermore, there are fewer branches of the radial artery in this region, reducing the risk of inadvertently puncturing branch vessels. When injecting local anesthesia, care should be taken to not inject an excessive amount. Excessive subcutaneous anesthetic before puncture can lead to swelling at the puncture site. This, in turn, can hinder the operator's assessment of radial artery pulsation, thereby increasing the difficulty of the puncture. To avoid these issues, it is recommended to insert the needle at the predetermined puncture point and create a subcutaneous wheal by injecting a small amount of lidocaine. Then, proceed with the needle insertion while aspirating on the syringe. If no blood is aspirated, continue with the injection of lidocaine. It is essential to avoid direct puncture of the radial artery during injection of local anesthesia, as it can lead to vasospasm and make the puncture more challenging. Additionally, avoid deviating too far from the intended puncture point to prevent unnecessary discomfort to the patient. When beginning radial artery puncture, use your thumb and index finger to grip the junction of the inner and outer sheaths of the puncture needle. Ensure that the beveled needle tip is facing upward. Insert the needle slowly at the intended puncture site at a 30 to 45 degree angle, making sure to proceed at a slow, deliberate pace. Feel for the relationship between the needle and vascular pulsation. Ultrasound guidance can also be used to increase puncture success rates and ensure patient safety. If the puncture attempt is unsuccessful, avoid withdrawing the puncture needle immediately. Carefully assess the relationship between the puncture needle and vascular pulsation. Then, if necessary, withdraw the needle and reattempt the puncture, ensuring accuracy and minimizing potential complications. Once more, ultrasound guidance can be used to increase success rates and ensure patient safety. Should radial artery spasms occur, nitroglycerin can be given to alleviate them. In cases where difficulty persists during the puncture procedure, or if complications arise, it may be necessary to consider changing the puncture site or the operator. This decision should be made to ensure the safety and success of the procedure. Once the puncture needle is safely within the radial artery, the syringe can be removed and a guide wire inserted. The needle can then be removed with the guide wire remaining in place. The sheath and dilator combination can then be inserted onto the tail of the wire. A small incision may need to be made in the skin to accommodate the sheath. Ensure that the tail end of the guide wire is visible out of the proximal end of the sheath, so as to prevent loss of the guide wire within the blood vessel. Once the sheath is fully advanced with a twisting motion, the guide wire and the dilator assembly may be removed. Use a syringe to aspirate and evacuate air from the sheath, followed by the administration of heparin and nitroglycerin. Other medications can also be considered for vasospasm. When the radial artery has a tortuous course, sheath insertion should be done under fluoroscopy. Potential problems may arise at any point during the procedure. If there is poor blood flow from the distal end of the puncture needle, three main possibilities can be entertained. The first is that the puncture needle bevel may not be fully within the radial artery lumen, and instead be on the anterior or posterior wall of the artery. Operators can adjust the needle depth and insertion angle to ensure the needle tip fully enters the vessel lumen. Ultrasound can also be used to fully confirm needle tip position. Second is radial artery spasm. In most cases, the use of a guide wire enables smooth advancement and negates significant obstacles to establishing radial artery access. However, medications, such as nitroglycerin, can be given to reduce the severity of vasospasm. Third is entry into an arterial branch. This should be entertained if guide wire advancement is difficult and not improved with adjustment of the puncture needle angle or position. The likelihood of this increases when the puncture site is too close to the wrist. It may require repositioning of the puncture site further towards the proximal end of the forearm before attempting the puncture again. If resistance is encountered during guide wire insertion, three possibilities can also be entertained. The first is that the guide wire has entered a radial artery branch. This typically presents as resistance when advancing the guide wire after partial insertion. Fluoroscopy should be considered for confirmation of the guide wire's course, and repuncture can be performed. The second is radial artery tortuosity. Ensure that the guide wire is positioned within the true vessel lumen. A switch can then be made to a longer, smoother guide wire to facilitate passage through the tortuous vessel segment. The third is that the puncture needle is pressed against the radial artery wall. This often results in immediate resistance during guide wire advancement. The guide wire should be withdrawn and its forward direction adjusted by rotating the puncture needle. The needle's insertion depth can also be modified before reinserting the guide wire.